Hi, my name is Jacqueline Hatcher, first year student at the Chicago School of Professional Psychology at Xavier University of Louisiana. And I'd like to talk about enhancing treatment of racial trauma in clinical practice. This poster examines ways that clinicians may adapt or supplement evidence-based practices in assessment and treatment to ensure that racial trauma is adequately addressed in clinical settings. Some of the disparities among and the impact of trauma among African Americans are the prevalence of PTSD is higher among African Americans than other groups. African Americans have lower rates of recovery from PTSD compared to white Americans. African Americans have limited access to quality mental health treatment, and the lifetime prevalence of exposure to traumatic stressors is higher among African Americans than other ethnic groups. We look at the criterion of the DSM-5 for PTSD, and it requires exposure to an extreme stressor involving direct, actual, or threatened death or serious injury. This criterion may not adequately capture many types of experiences that have an adverse impact on African Americans and can go unrecognized in treatment, such as perceived discrimination, microaggressions and covert racism, historical trauma, witnessing racially motivated traumatic experiences in the media or in one's community, such as hate crimes or police brutality. Racial trauma has been defined as a traumatic response to a race-related adverse experience, including prejudice and discrimination. These experiences may have a cumulative adverse effect. And some of the effects of exposure to race-related stressors are they can produce symptoms that are often associated with traumatic stress reaction, such as anxiety, depression, dissociation, and sleep problems. Perceived discrimination is associated with a range of psychological distress symptoms among African Americans. Perceived discrimination has been associated with physiological stress responses among African Americans, such as increased cortisol secretion. Sabrava et al. Found that perceived discrimination predicted PTSD diagnostic status among African American and Latinx subjects, while also being inversely related to quality of life and social adjustment. When we talk about the disparities, we talk about the criterion, we talk about the effects. Now we want to apply it, and how do we reduce some of the disparities in clinical practice? And researchers have come up with measures in stages of research, but they have reliability and validity to be able to assess for racial trauma, such as the race-based traumatic stress symptom scale, the Yukon Racial Ethnic Stress and Trauma Survey, the Trauma Symptoms and Discrimination Scale. They make it where the discussion of racial trauma does not have to be uncomfortable. And then while we don't have empirically supported intervention designed specifically to treat racial trauma, there are existing empirically validated treatments for PTSD that may be adapted to enhance sensitivity to racial trauma, such as prolonged exposure therapy for PTSD. And then finally, the recommendations for clinical research and future research, clinical practice and future research are clinicians should explore and assess clients' experiences related to various aspects of racial trauma, even if the experiences do not meet DSM-5 criterion A for PTSD. Clinicians should convey a willingness to explore the cultural context in which traumatic events occur. Clinicians and researchers should make efforts to adapt existing evidence-based practices to enhance their sensitivity to race-related stressors, and further research is needed to establish the validity and clinical utility of measures of racial trauma. Thank you for your time.